Can I have everyone's attention, please? So we're going to begin. First of all, welcome. We're welcoming everyone here tonight, and Dr. Lawless, who is coming from Georgetown, so thank you so much for coming. I wanted to tell you a little bit about what your donations have done over the past year and coming up, because I think it's key to our mission. Starting in October, we actually published a book through Dr. Henderson on craniocervical instability and came to a consensus in that on how a neurologist, a neuroradiologist, or a neurosurgeon should actually measure for those to determine whether cranio instability is present or not. And it was probably a group of about 25 neurosurgeons, so to get them to agree on anything, and they came to a consensus, is quite telling about our group. That's a miracle, yes. So that's really exciting. Coming up, we're going to have 3 medical meetings starting on May 1st. On May 1st, we are meeting with the NIH and the NINDS to actually work on the international registry. And to give you a brief idea of what CSF has done for this, we've had a weekly meeting every Tuesday night from people around the country, and what the NIH asked us to do was to come up with like a dictionary, common data elements or common data instruments that would be used by researchers around the world, so that we're comparing apples to apples when they do research. And going forward, this registry will be uploaded onto the NIH site and the NINDS site, and then if a researcher wants to apply for a grant, they're going to have to use those elements. Otherwise, they're not going to fund them. So we've funded this so far, and I think it's going to change the way research is done in the future. So it's a huge step. Takes an incredible amount of time, an incredible amount of work, but we're really doing it. On Saturday, May 2nd, we're holding our think tank symposium, and we're going to talk about new thoughts on pseudotumor cerebri, and we're going to educate a group of neurosurgeons on dysautonomia. So I think it's going to be an interesting day that day. And then on the Sunday, we're actually going to look, we have a group coming together to look at the whole conundrum of what goes into, with Chiari, dysautonomia, EDS, having that all together, chronic fatigue, all of those elements, mast cell, to educate neurosurgeons, neuroradiologists about the whole picture. And it's still so unclear to a lot of people that we really want to further that discussion. And it's really going to be a roundtable discussion rather than a formal presentation day. So that's May, first weekend in May, which is huge. Then we have in July 7th, we have bioengineers and fluid dynamic people coming from around the world to meet in France to look at Syringomyelia and cerebrospinal fluid flow, and it'll be hydrocephalus as well as Syringomyelia, and what are the causes, and how to look at this from an engineering perspective rather than from a clinical perspective, to hopefully solve some of the problems that our clinicians are having. So that's from the 7th to the 10th in July. Then we have the colloquium, which is going to be in October. So the topics haven't been sorted out as of yet, but we're talking about 4 or 5 major medical meetings this year that I think will help further some of the questions, further some of the answers to the questions that we have. So just so you know, all of the talks are going to be uploaded online, so you will have access to them and you get to hear them. So we're very excited about that. And if you have any questions. No? So at this time, I'm going to turn it over to Dr. Henderson, and who's an amazing man, and really, he's been so helpful in getting all this together for CSF, so thank you very, very much for your help.
Thanks, Dorothy. We are very honored to have some distinguished guests this evening. And it's ironic that great things happen in small places like this evening. But we have two people here tonight who have made profound insights into the way cancer can be treated and neurodegenerative diseases can be treated. And they're sitting right in front of me. So I'd like to, but before introducing them and the work of Dr. Lawless, I'd like to invite Pam up here to speak and give her testimonial. One of the, Dr. Lawless and I were talking just a few minutes ago, and we were both remarking on how we learn most by listening to our patients. And I think with EDS in particular, I've learned so much from all of you all. And I just speaking to this young man earlier this evening, and he's teaching me about new drugs that I'd not used or really knew anything about. So I made those notes, and I think every day I learn a great amount from the patients. And so that they have been my teachers every bit as much or more than the professors at University of Virginia, Georgetown. Anyway, exemplary amongst and emblematic of our brilliant patients is Pam, who has done so much amongst the patients to help them on a personal level and to also help with national meetings, the annual gala, and many other ways. And she herself has had some amazing insights into the epigenicity of disorders, or how certain factors can have an epigenetic influence on Ehlers-Danlos syndrome. But I'd like to invite Pam up here to speak and give her testimonial.
I was asked by a friend recently to write a piece just about what this journey meant to me. So it might be a little different than when we all get up here and tell about all of our ailments. But where I am at this point of time in this journey, I wanted to share with you. So I titled this Life is a Gift. And I started it out with a quote by Lorna Wilson. Life is a gift, regard it as such. Return the blessing through each life you touch. Every seed planted springs forth new birth. Allow your bouquet to cover the earth. My world had been rocked to the core. One doesn't imagine their life can change in the blink of an eye. I never imagined handing my daughter over to a neurosurgeon 4 times. Now I know it, sorry, I'm going to be emotional. Now I know that number will only increase over the years. I never imagined that I would need a brain surgery along with a spine surgery to attach my skull to my neck just to stay alive 5 years ago. I never imagined more brain surgeries would be in store for my daughter and I. I never imagined more spine surgeries would be in store too. Living with Chiari and Ehlers-Danlos syndrome teaches you to expect the unexpected. Be prepared. When they check your heart, they're going to find something major. Be prepared. They're going to find something major in most of the other places too. EDS involves a defect in collagen, which makes up the entire body, so even your blood vessels will be affected. Be prepared to find out these conditions have no cure. Surgery is only a band-aid, but worse, these conditions are poorly understood and lack research and funding. Be prepared to have to arm yourself with knowledge so that you can be the best possible advocate for yourself and for your children. You unknowingly pass this on to them, and it will become your job to bring everyone up to speed. You will fight for your lives until you make it to a doctor who understands and can help. There will be plenty of days when you can barely lift your head off the pillow, but you will have to, because your child is suffering too and needs you. The surgeries, the daily pain, all of the medical appointments, dealing with insurance, the mounds of medical bills, they can suck the life right out of you. Just when you might start to see light at the end of the tunnel, something else rears its head, and you're thrown right back into the abyss. At some point in time, you accept the hand that you have been dealt. You convince yourself that just because you have these conditions, it doesn't have to mean that they have you. You learn to put on a great game face. You become quite good at suffering, and you smile to hide the pain. You become kinder as you realize that everyone faces battles and that theirs are just different from yours. I have always had what I thought to be strong faith, but evidently God thought it could stand to be a lot stronger. The storms kept coming over the years, and every time I would let worry, fear, and stress consume me, I learned to live in survival mode. When my daughter's Chiari symptoms were the worst, I would go into her room several times a night to check on her, just to make sure she was still breathing. My son had blood sugar that plummeted, especially during the night, and I would go into his room and check his blood sugar while he was sleeping. I never slept back then. My daughter would have one surgery and start to do well, and then things would go haywire again, and she would develop a new problem. In my son's case, it took 9 years to get to the root of his low blood sugar, a rare carnitine deficiency. His doctor asked me if I was sitting down before she delivered that news to me over the phone. In the midst of things, I had my own serious problems that needed attention, but we learned to survive daily by triaging who was worse. I squeezed in my surgeries when an opportunity would present itself, and the light at the end of the tunnel would start to dim again. The stories I could share are unimaginable to most, and unless you lived under our roof, you really have no idea. Things never let up, and the stress, fear, and fatigue were draining. There was no end in sight. This was our life. This is our life. Surgeries and treatments over the past few years have certainly been miraculous, helping so much. But when you live with chronic conditions, there never is an end in sight. The stories will remain unimaginable. Today, I no longer fear the storms. They have made me stronger, and because of them, an indomitable spirit now resides inside of me. The storms have taught me that worry and stress won't ever change the outcome, but that they will take away from the day's sunshine. I learned that fear does not prevent death, but instead prevents life. My faith is much larger now. It is impossible to endure difficult times without huge faith. There is no reason to live in survival mode once you let go and let God. I have been given the opportunity to see life through a different set of eyes. I now see everything I didn't notice before when I was too busy and too distracted. When you don't have your health, you learn very quickly what a precious gift life really is. You begin to not take one day for granted, and you realize that the secret to having it all is already knowing that you do. Perhaps I have been given a gift wrapped up in a daunting medical diagnosis. Thank you.
Pamela just had surgery about a week ago, I think, so she was very brave to come up and give a talk, right? Just 1 week after surgery. We're very honored tonight to have a number of guests. Dr. Decker from Baltimore will be arriving soon. Dr. Miles Kobe, a neuroradiologist, I think, who has contributed greatly to the understanding of what's going on in the brain and the spine. We've done a lot of work on finding thrombosis, sinus thromboses, abnormal circulation of the brain, and abnormal anatomy of the brain and spine. Dr. Lee, who's my colleague, trained at Johns Hopkins, Mass General, and he runs a marathon every other week. And he's been very helpful with these patients. I think he held someone's neck in the emergency room for about an hour and a half a couple of weeks ago under traction. Dr. Andre Salazar, I've known for many years, first when I was in the Navy at Bethesda, and Dr. Salazar is a colonel in the Army, and he has done some very innovative research using single-stranded RNA to treat cancer, and he set up a multi-centered study about 20 years ago that demonstrated that this was one of the first treatments of glioblastoma that actually seemed to make a difference. As usual, funding is always an issue, but he's still working on this vein of treatment and has now made new inroads into the understanding of how we treat cancers with RNA particles. And I thought it was particularly great that he's here this evening because Dr. Lawless is using a similar theme to stimulate T cells in the treatment of neurodegenerative disorders and inflammatory disorders of the brain. And we all know that patients with Ehlers-Danlos syndrome appear to have a proclivity to inflammatory disease of the brain. And so this is one more comorbidity that we are looking at. And speaking of which, we have eminent Claudius Austin, who gave a wonderful talk several months ago on the treatment of neuroinflammatory disorders. Good to have you, Dr. Austin. Dr. Lawless is from Ireland, and I thought the name Lawless was interesting. Apparently it doesn't mean, without law. It's a Gaelic name. But he was graduated in 1961 from the National University of Ireland, University College Dublin in medical school. So I think he must have been about 15 at that time, 1961. And he then did his residency at St. Vincent's in Dublin and worked at Boston University. Came to Walter Reed, where he was director of the immunology laboratory and then director of allergies and immunology at Walter Reed from 79 to couple of decades. He was a colonel in the Army. He's now a professor, adjunct professor of pediatrics and immunology at Georgetown University, where he's director of allergies, immunology, and environmental disorders. He's won several national prizes. He's published extensively. He's given lectures all over the world. And he has graciously offered to come and speak tonight. And I can tell you that the two senators who are very interested in this work, who could not be here, and others who are watching on the sidelines, who are very interested in Dr. Lawless's work. So I'd like to introduce guest Professor Lawless. Is there a...
We need an expert here.
Oh, just hit any button.
Oh, that's right. Well, the title of what we're going to talk about is the epigenetics of lupus, Alzheimer's, Parkinson's, and ALS. Now, my background is in rheumatology at Walter Reed, and we had, when I got there, we had 20, 30 lupus patients. When I was leaving, we had 600 on the books. And we had a serum sample stored in every one of them. Can't do that anymore. Doesn't allow us to store anything without permission. The background to all of the disease is genes plus environment. And the combination produces disease. But the environment is getting more and more complex, and we're going to go through a lot of this as we talk through the talk. Definition of epigenetics: alteration of gene function without gene alteration. And within the gene you have DNA, you have histones, and you have RNA. So any one of these can be altered from outside and change the pattern without altering the gene itself. And that's a fundamental issue as we were talking about cancers, but also in lupus, and we'll talk about that as we go through. The immune system is divided into innate and adaptive, and you all know this. And in the brain it's slightly different because of M1 and M2, which is a macrophage. But in the brain it's an astroglia, or another glial cell. And the M1 puts out all of the inflammatory IL-1, IL-6, TNF. But the M2 lays down fibrous tissue, and heals the lesion that was started by the M1. The adaptive, you have T cells and B cells, and we talk about THO, no surface marker, then TH1, TH2, TH17, gamma delta T, and the B cells are IgM, IgG, A, E, and D. Gene function, from your biochemistry, you have transduction, translation, and transcription. Here is a good model which I pulled out of Wikipedia, which is the current dictionary of ease of access. But the key is the gene has to open up and expose the strands to messenger RNA, and it, as in the unopened fashion, as you can see in the middle of the bottom of the slide, the histones are wrapped around the DNA and they're non-functional. But when they're opened up like they are here, and they can be altered also, so you can alter the histone tails by epigenetic factors. You can alter the methyl group on the CPG of the DNA sequence, and you can alter the RNA, all of which modify the functionality of the gene without changing the anatomy of the gene. Now, when you get new mutations, it causes new antigens to be produced, and the body is, we talk about self versus non-self. Self-antigens are non-antigenic, or self-proteins are non-antigenic. They do not cause inflammation. But if you alter self by RNA or other modifications, they become antigenic. And the dogma is self is non-antigenic, non-self or altered self is antigenic. And human mammalian DNA is methylated and non-antigenic, but lupus DNA is demethylated and antigenic and causes lupus. Now, how this epigenetics data became important was the finding that in identical twins who are discordant for SLE, the peripheral blood mononuclear T cell DNA is demethylated in the affected twin, but it is methylated in the normal twin, which is fascinating because they have now published a similar study on Alzheimer's disease, that the DNA in the twin that is affected is demethylated and the twin not affected is methylated. In lupus, we used to have 2 genes, DR2, DR3. Now we have over 30, and I stopped counting them when I was doing my last bit of research, because when we had 2 or 3, I asked 2 and 3, I asked questions like, if I know your gene and I know your antibody, can I know the manifestation of your disease? And the answer is yes. DR2 makes anti-DNA, but it is not double-stranded. DR3 makes antibody to double-stranded DNA and causes nephritis, which is a bad outcome in lupus. So if you had DR2 and had lupus, you had a good prognosis. If you had DR3, your prognosis was not as good. And the importance here is that lupus is an autoimmune disease, so it's antibodies against DNA, but now we have 100 antigens. So you have DNA, SM, RNP, RNA, and it goes on and on and on. Now, the next question is, how does the environment get into this? Well, we have air, water, food, medications, inert contaminants in normal pills. And there's a website called RX List, and if you ever want to look up your pills to see do they have aluminum, mercury, silicon dioxide, titanium dioxide, this RX List will give you the inert ingredients that are all approved by FDA. And I'll tell you a story about that. I had a patient who had his 3rd episode of knee grafting because of bad knee arthritis. He came to me and I would take off 100 cc's of fluid every month. And suddenly I asked him, I said, what are you taking medicine-wise? And he told me his list of medicines for hypertension and diabetes. And one of the medicines had titanium dioxide in it. I sent him to the apothecary in Bethesda, took the titanium out of his medicine. His effusions went away and never came back. And that's 3 years from now, in the past. Next is implants. We're implanting everything. Breasts, nose, buttocks, joints, heart, stents. Silicon, platinum, iridium are in many of these metallic implants. And we did several studies years ago on how the body reacts to silicone, silica, and silicate, and it does. And inflammation is caused by immune system, but if you take medications like hydralazine for blood pressure, procainamide for heart, and silica, they cause lupus in a genetically susceptible patient. When you take the meds away, the lupus goes away. So it's causality between the medications you're exposed to and the disease. So we talk about stress or oxidative stress, which is reactive oxygen, reactive nitrogen, prostaglandins, cytokines, chemokines, innate activation, self-alteration, and new antigenicity. And what we call the metabolic syndrome, which is obesity, diabetes mellitus. And it's intriguing because now there's more and more evidence that the metabolic syndrome is a disease in itself because it causes diabetes. And the key here is the DNA is demethylated by these inflammatory molecules, and therefore it is why it is antigenic. Now, the final mechanisms of how inflammation takes place is by two entities within the cell, the NF-kappa B and the inflammasome. This is the NF-kappa B produces IL-1, IL-6, TNF-alpha, which we see in rheumatoid arthritis and psoriasis and all of these inflammatory diseases. The inflammasome is seen in gout, pseudogout, and in Alzheimer's disease, and it produces IL-1 and IL-18. And it's of interest that if you have, maybe we'll come to it later, but IL-6 changes regulator T cells to become effector T cells, so the presence of cytokines may often alter the functionality of the T cells and change them from what they should be doing. Now, this was done when I was at Walter Reed, and what we did was we took mammalian DNA, which was methylated, went to one of the suppliers, ordered a bunch of calf thymus DNA, had it sequenced by a head of biochemistry, and he cut the molecule into 100,000, 50,000, 10,000 molecular weight, and then we took that and different antigens to see if it could stimulate T cells from lupus and normal people, and we found it didn't. And that posed very interesting questions. So, being a stupid Irishman, I said, if it doesn't cause activation, what if it causes suppression? And that's what we found. Now, loss of suppressor regulator T cell function in lupus was first noted by Barry Bresnahan, who is another Irishman who worked with Morris Ziff in Dallas. And recently, Lipsky's group at the NIH found marked reduction in Tregs in lupus. So the question is, if we could upregulate Tregs, we might be able to solve the lupus conundrum. But they're not just in lupus, they're decreased in allergic rhinitis, asthma, rheumatoid, psoriasis, Crohn's, colitis, MS, Alzheimer's, ALS, Parkinson's, aging, infections, HIV, and chronic infectious diseases as well. If you reconstitute, you correct the deficiency. So the methodology for this is you take normal cells incubate them with an antigen, alloantigen or mitogen for 3 to 7 days, and then you add equal numbers of autologous 48-hour pre-treated cells with either concanavalin A or double-stranded DNA. So you have two sets of cultures. You take my cells, put them in culture for 7 days, add antigen like streptokinase, streptodornase, lipopolysaccharide, one of these regular antigens, and then run them for 7 days in the presence of 48-hour treated autologous cells with the presence of ConA or double-stranded DNA. And the idea is that the ConA or double-stranded DNA activates suppressor cells. So what we found was background counts per minute with calf thymus alone, normals for lupus 9. We saw no blastogenesis of T cells in culture with this antigen. So the question was, is it inhibitory because it's not stimulating? And that's what we found. And here is the three different colors, serum alone in the dark purple, or I guess it's mauve of some form, and the second one has one microgram of DNA here, 10 microgram here, and at the 10 microgram addition, all but one of the patient's cells fell down drastically. So the summary is that normal and 8 of 9 lupus patients' blood responses to antigen streptokinase are suppressed in the presence of added 10 micrograms double-stranded DNA. Similar data can be shown for responses to PHA, CON-A, and pokeweed mitogen, all non-specific stimulants, so all cells respond. So here are some data, and if you take the 24-hour, 3-day cultures of PHA, CON-A, and pokeweed on this line, and then you add the CON-A activated 48 hours to these same cells, and you see a reduction of 30%, 36% with CON-A, and 25 and 24% with DNA. Single dose, which suggests to us that indeed DNA is activating suppressor T cells. Now, when we did a dose response curve at 1, 10, 50, and 100, we dropped the counts in the indicator cells from 11,000 down to 800, which is huge. And here is the same thing on the graphic display. And the results are a significant reduction in counts per minute of normal cells in response to CON-A in the presence of 48-hour PBMs pre-treated with either CON-A or double-stranded DNA. When you mix patients' lymphocytes from one patient to another, A alone is me, A plus B is you, because they're alloantigenic. Therefore, you'll see a response, and the response goes from 200 to almost 5,000. But if you treat with CON-A or DNA, you get a 72% inhibition of this allogeneic response to either CON-A or double-stranded DNA. The next we did is lupus serum is potent in terms of antibodies. You have DNA binding percent. The maximum you can get is 100%. So if there's more than that, you've no idea how high it is. So we did DNA binding percent, DNA binding capacity, which is the micrograms bound per milliliters of serum, binding avidity, interferon levels, immune complexes measured by C1q binding, and then complement levels and IgG. And these are all very important measures in lupus to say who's going to get worse or who's going to get better. When we did on the bar graph here, you can see that the maximum binding capacity inhibited lymphocytes more than smaller binding capacities. Summary of this is calf thymus double-stranded DNA activates a normal donor suppressor regulator T cell when tested on autologous PBMs and in one-way MLCs with a percentage inhibition comparable to CON-A. And this was based upon the work by Robert Good, who was the giant in immunology many years ago. The inhibitory effect, appears to be dose-dependent and is abrogated by prior DNase treatment. The inhibition of antigens, mitogens, and MLRs is consistent with the induction of suppressor regulator T cells with bystander and allogenic suppressive function. These results show that mammalian calf thymus DNA is non-antigenic to normal or lupus PBMs, inhibits antigen, mitogen, alloantigen induced blastogenesis in vitro, appears to be dose-dependent, abrogated by DNase treatment, so it's specific for the antigen we're using, which is DNA. And this suppressor T cell activation appears to be dose-dependent and CpG dependent. So the methyl group on the DNA is the critical factor in this sequence. When we did another assay, pretreatment of autologous donor cells with CON-A resulted in inhibition of counts of 30% for PHA, 36% for CON-A, and 17% for pokeweed. Calf thymus did similar, 24% for PHA, 24% for CONA, and 1% for POPI. This is again the allogeneic study in the presence of CONA and DNA, and with the CONA activation you suppressed allogeneic activation by 72%. With DNA we found it inhibited by 52%. Now the question is, what about immune complexes, interferon, DNA binding? On lymphocyte transformation, and what you can see here is that there is this was patients treated for 40 days with cortisone equivalents. And you can see that cortisone works very well in getting rid of these antibodies present in a time sequence. And obviously it's dose dependent as well as time dependent. On the basis of this, we filed for a patent which was awarded to us in February 2011 on a vaccine composition containing methylated DNA with immunomodulatory motifs. We call it MetVax Bio because of the methylated component, but it's not a vaccine in the true sense of a vaccine because its effects are short-term. Vaccines should last longer, and you boost the immune response. This is a biologic that is temporary active. And the question is, are we planning to administer it? You can do it by injection subcutaneously. You can do it orally, sublingually, intranasally, because it's a non-active in terms of, we're ready to take it to the next phase of IND approval for in allergic rhinitis. We mentioned before that the discordant twins with SLE, the affected twin T-cell DNA is demethylated, non-affected twin DNA is methylated. And we mentioned this before. Interferon is very high in acute SLE, and the question is, does it play a role? And the answer is, it is also demethylated in the active disease. So demethylation seems to be one method of altering a self-antigen that makes it immunogenic. Now, let's go to the more global side of the environment. In 1980s, there was an epidemic of neurodegenerative diseases in Guam, and ALS, Parkinson's, and Alzheimer's were all prevalent with increased frequency. There was a huge series of articles over the years, and it really hasn't been sorted out because one of the possibilities was that there was a plant neurotoxin that was doing the same thing. It has not been resolved, but it's just important because you get the information from funny places. And as Fraser was saying, you have to listen to patients because the patients know where they're being exposed. Treatment of Alzheimer's with NSAIDs is a series that went on for years, and there are several papers by the McGears showing that as you use NSAIDs, it slowed memory loss. The problem is these are frequently older people, and the NSAIDs that are most powerful have bad side effects with GI bleeding, etc. On Code Red days in Mexico City, mortality increased. And there was a paper, several papers on this by Calderon, Grassi, Judenas. And what they did was they took these patients to autopsy after death and found TNF-alpha, amyloid beta protein, in the mucous membrane of the nose, the olfactory nerves, and the frontal lobe of the brain, suggesting that the pollution in the atmosphere goes through the nose and gets into the brain. And my thought was, if that's nature's way of doing this, we should simulate it by putting the vaccine in a nose spray to deliver it to the same place. In Mexico City, another paper, Children ages 12 to 14 are developing memory loss, tremors, and Parkinson-like illness. In Alzheimer's disease, inflammation causes amyloid beta protein and tau protein in the CSF and also in the brain parenchyma. Now, these are inflammatory molecules. I did my fellowship in Boston with Alan Cohen, who is the world authority on amyloid induction, and we could do it with milk proteins, we could do it with lipopolysaccharides, and a whole host of different antigens. It didn't have to be just the milk protein. And we found that in mice models, antibody to amyloid beta protein may lessen the memory loss. The gene for amyloid beta on incubation with peritoneal macrophages causes amyloidosis. So here is the gene that is responsible for amyloidosis. And I mentioned the study twin studies for DNA T-cell methylation, a single paper on Alzheimer's disease that the discordant twin was demethylated. Another series of questions. Chloroquine can shut off amyloidosis in the mice, and methotrexate maybe also. And chloroquine works at the M1 phagocyte, so it stops the inflammatory process. Amyloidosis can be transferred by spleen cells in mice to rabbits, heterologous, and the presumption is that it's a macrophage transfer, not a T cell or a B cell. Treg cells suppress M1 inflammatory interleukins and interferon gamma. Also, they suppress effector Th1 cells. And there was a single paper by Dr. Tobinik, who basically gave Enbrel into the Batson's plexus in the back of the neck on the basis that you can't get an injectable item into the brain. And he found within 1 week, and it's a fascinating paper to look at because he described the interview with the patient who happened to be a doctor, and he could not speak or remember names or words or anything. 1 week later, after the Enbrel, he had complete, I won't say complete, but significant improvement in his memory loss. In Parkinson's, alpha-synuclein is in pars compacta is the dominant antigen, but Parkin, there are 5 different genes or other antigens in this, and dopamine also is a critical antigen. Now the question is, which of these is the critical one and which of it is methylated, demethylated? And I'm not aware that these studies have been done as of now, but it's clearly where we need to go. MHC deficiency, which is what presents antigens to B cells in animals, attenuates the disease. Apoptosis, nerve cell death, increases memory loss. Tregs, Th2, and M1 lessen inflammation and nerve cell death. In animal models, T cell deficiency attenuates the disease, suggesting that the T cell may be equally or more important than the B cell in producing the disease we know as amyloid beta protein. So we have a summary here. We know some antigens. We know antigens are induced by the environment, but is it the antigen that is from the outside that is causing the amyloid deposition, or is it a new antigen based upon modulation of the amyloid beta protein? And answer is not in, but it's a very important question to ask. Now, the disease that fascinated me was the paper. I was ordering some of my sequences from a supplier, and he said to me, "What do you know about ALS?" And I said, "Not very much, but I'll look it up." And I looked it up and found that in ALS, Tregs are markedly decreased, And if you have very low Tregs, you're dead within 6 months if you have ALS. So therefore, a question of can we increase the Tregs with a view to neutralizing the negative effect. The other is important is silica is increased in Persian Gulf War illness and in the World Trade Center illness. And in fact, sarcoidosis is now of huge prevalence in the first responders and the firefighters in New York City who were involved at 9/11. So the treatment options you have to look at as a clinician, what is the trigger and can you find them? Can you avoid them? Monoclonal antibodies to IL-1, IL-16F alpha are potential because the inflammatory cytokines can cause inflammation. Neutralized demethylation, DNA, histones, microRNA, all of now is going on in the cancer world because all of this is feasible. Some years ago we couldn't do it. Now it's all open sesame. You increase Tregs by IVIG, intravenous immune gamma globulin, increases significantly Tregs, and it also neutralizes NF-kappa B and inflammasome activity, which is what is turned on by the amyloid beta protein. Theracos extracorporeal photophoresis. Anybody know anything about this? They wheel up a machine to you, take 500 cc's of white cells, kill them in a test tube, and reinfuse the products. Well, it turns out that cell death of lymphocytes in humans liberates methylated DNA. Lupus DNA is demethylated. So in fact, what they're doing on the Theracos experiment is giving back methylated DNA to the patients. And it works. They've done over 500,000 treatments. And they're treating basically transplant rejection, but also lupus, scleroderma, and other chronic inflammatory diseases. One issue here would be if you could take the patient's cells, isolate them, and trigger them with an antigen that upregulates Tregs, you then could make billions from the same patient and reinfuse them. Nobody has done this at these diseases, but they have done it for other diseases. And finally, a better understanding of the FOXP3 activation. We still don't know what is the nature of the trigger of Tregs by this double-stranded DNA. And there was a paper just last week from Sakaguchi's group in Japan where they've actually shown that there may be 100 to 200 regions of the gene in Alzheimer's that are demethylated. So how that affects the FOXP3 activation is a major question. And the questions I'm asking at this point is, does the active sequence activate T cells into Tregs, or does it pre-select Tregs and amplify them? Fundamental question that we're trying to do a collaborative study in this area. The next is, if you put more than one methyl group on the sequence, is it more important than just one? And we have now 6 different sequences where we have 1 methyl group, 2 methyl groups, 3 methyl groups to answer that question. Pollution role. I told you the story already. Mount St. Helens, the eruption on the west coast, the plume came around the entire United States and came back and was measured in San Francisco 1 week later. The volcano in Iceland, very high in silica, went around the world also, and I have photographs of the wind patterns that we'll see in one of these slides. And also there was an epidemic of sarcoidosis in Iceland after the volcano eruption. Mexico City deaths and autopsies mentioned. The London smog deaths and autopsy in 1952. They found silica in the nasal mucous membrane, in the mucus, and in the draining lymph nodes in and around the head and neck following the London smog. And this was autopsy studies. Now, Gulf War illness is an issue because there's an increased frequency of ALS and then also an increased memory loss and traumatic brain injury and the like in Gulf War illness. And in the World Trade Center illness, very high silica and asbestos, and the winds from China, Mongolia, and the Gobi Desert come around the world and have been picked up in Hawaii weeks after the event. There was an article in Discover magazine by Karen Wright in 2005, and here's the data. An analysis of the Hawaiian soil found that some of its quartz content is derived from the Gobi sand. Satellite data have since confirmed that a dust corridor extends from China to the Hawaiian archipelago and then continues on to the North American mainland. So we're not in a divided world anymore. We're all together in this small planet. And here is the picture of the prevailing winds from west to east. And coming from that small little place called Ireland and looking at Iceland just above it is a fascinating picture. If you know about MS, MS is not a disease you see in the tropics. It's northern climates. And when I looked at this and asked the question, the prevailing winds from the from the Icelandic volcano, it cut Ireland into two, separating south from north, and there was a prevalence increase following that of MS in north of Ireland, not found in southern Ireland, probably related to the volcano. And this is pictures of PM10s, particulates measuring 10 micrograms or less. And you're allowed by EPA less than this. And this was taken in China, in Beijing, during the China Olympics. And you can see massive accumulation of pollution in China. I would not like to be doing a marathon in this weather. This is another example of what you call the blue sky index. You can see the blue sky, but you can't see it here at all. And that's a measure of the severity of the pollution. And this is the London Tower Bridge during the London smog. And when you look at these particles, and this is from Wright's paper, you can see particles that are basically crystals. And not alone do you get crystals, but you get fungus present, as you can see that in the center. So the pollution can carry bacteria, fungi, viruses, as well as crystalline material. And the closing thought is taken from a British surgeon, John Hunter, in 1794. When inflammation cannot accomplish that salutary purpose of which it is intended, it does mischief. And the mischief is what I've been talking about.
Questions from the audience?
You have this your new vaccine for controlling inflammation. You're going to try this in lupus first?
No.
And okay. And how far are you from clinical trials?
Well, we're going to try and do it on Blau syndrome.
On what?
Blau syndrome, which is an autoinflammatory disease of childhood with juvenile sarcoidosis.
Okay.
Because it then gets into the orphan category. And we don't need the big numbers that we will need if we do allergic rhinitis or lupus.
And you're close to starting?
We have it, we just need the funding. You and me and everybody else. Yes.
I just have a curious question. I've noticed in a couple of my friends who have developed autoimmune diseases just within a few months after getting tattoos. Can you shed some light on that?
I do not know what's in the tattoo. Somebody probably in the audience does. But it's a foreign body. And if it is contaminated with anything, as it could be, it's another antigen that sets up inflammation.
You listed a number of particles that could influence gene expression. It looks like anything in the environment ingested can alter gene expression. Is that the case?
If it causes inflammation.
Yes.
And the gene, and it looks like that inflammation causes metabolic syndrome, inflammation, demethylation of the antigen. So there's something unique about the inflammatory process that is causing this sequence of epigenetic change.
Just out of curiosity, I found it very interesting. You talked about the ALS-PD Guam. I had the good fortune to work with Carl Gadjusek, and we described a focus of ALS, Parkinsonism, and dementia, probably one of the highest incidence focus in the Key Peninsula, not in the Key Peninsula, there are several areas, the Key Peninsula, Japan, Guam, and we described it in West New Guinea among two very primitive tribes. And essentially, we looked at all kinds of things. We looked at all kinds of potential toxin exposures and so forth and so on. And what we came up with was that the one unique thing about the place where these people were developing this tremendous degenerative disease was very low calcium and magnesium and relatively high aluminum. But the aluminum was not really the issue. It was the low calcium and magnesium in the soil and waters over very chronic exposure. And then we did an experiment at the NIH in which I actually sort of had to design the diet and so forth. We took young monkeys, young rhesus monkeys, and we designed a diet that was purposely low in calcium and magnesium. And we put these animals on this low calcium, juvenile animals. Some of them actually were getting extracycad, which is the toxin that's been in.
Yes.
Make a long story short, I was then transferred back to Walter Reed and almost forgot about this. And then we got a call saying, hey, we still have these monkeys here 4 years later. What are you going to do with them? You're going to have to get rid of them. Well, we sacrificed them finally. And lo and behold, they were all showing, not the cycad ones, but the ones on the low calcium and magnesium were showing all the signs, neurofibrillary tangles, all the signs of very early ALS. And so then the question is, what were we doing from your perspective? Because we never were able to explain it. So here's a situation where low calcium and magnesium, and the controls didn't have it in the diet over a prolonged period of time in juvenile monkeys was causing incipient ALS. Would that be related to what you're talking about?
Probably, but again, it's speculation, without hard data. But the question is, silica is everywhere, and the Gulf War, the numbers were horrendous. You probably remember looking at the first Gulf War. You couldn't see what would I say? The people describing the whole thing were almost invisible because of the pollution. And we don't normally think about it, but it's huge. And I think the China story is very remarkable because of that.
There's a large subpopulation in the EDS community with mast cell activation syndrome. So you made a comment that when inflammation exceeds its salutary purpose, it causes mischief. How does the inflammation resulting from mast cell activation syndrome contribute to this epigenicity?
I don't know the actual mechanism, but it does potentiate Tregs, or alters Tregs in one way or another. It's considered in the same line of activation of Tregs as mast cells. And I'm not up on it largely enough to be able to discuss it any better.
Does it increase or suppress the T regulators?
Increases.
So that's good.
It should be good, but I can't tell you.
Can you talk a little more in layman's terms about the what that actually means, like
Demethylation.
Yes, and also about how you go about stimulating the T cells in layman's terms also.
Okay. If you take a blood sample, isolate the white cells, put them in a culture plate, and let's say 500,000, and you add an antigen, and you leave them there for 7 days, one cell becomes 2, becomes 4, becomes 8, becomes 1 billion. And we measure that uptake by feeding radioactive material, and the number of counts is the number of cells when you look at that. So you talk about counts per minute, which is the uptake of the thymidine into DNA. And that's how we get these numbers that are very accurate and comparative when you're doing the studies. You can stimulate T cells that you've so isolated by antigen, like streptokinase, lipopolysaccharide, E. coli antigen, that sort of thing. But in addition, they go on and respond to these mitogens, which are CON-A, pokeweed mitogen, and the pokeweed is a B cell stimulant, the CON-A is a T cell stimulant, so we can decipher whether it's a T cell response or a B cell response on the basis of the number of radioactive uptake that goes on.
And are they given orally, infusion-wise, or how are they?
No, it's all in a test tube.
All test tube.
And the patient is not exposed. It's just the cells are exposed in a test tube. Yes?
How does this relate to the onset or pathogenesis of some mental illnesses like depression and schizophrenia?
I'm glad you bring it up. Yeah.
I mean, well, recently there's been, a new form of mental illness called PANDAS, which is incited by streptococcal bacteria. So I was wondering if, like you were saying, how is inflammation involved in mental illness?
Well, the answer is it's looking more and more that inflammation is there, particularly in autism. And there was a report last weekend that Roundup, which is the pesticide, can cause autism, which blows your mind because we're all around this stuff all the time. And same thing is true about schizophrenia and bipolar disorder. They're beginning to see more and more inflammatory molecules in the brain of psychiatric illness rather than inflammatory illness. So, and we were very interested in fibromyalgia, chronic fatigue, somebody mentioned it. We found that we had 100 patients with silicone breast implants, and we found 60% had fibromyalgia and chronic fatigue, postural hypotension, autonomic neuropathy. And so to me, it's an inflammatory disease, and the group in Georgetown have shown that you can get brain inflammation as a manifestation of chronic fatigue. So I think we're getting into a whole new area that were unknown entities some years ago. Yes.
Are some people predisposed, or is it anyone who would be exposed to some of the contaminants that you talked about? If she and I were both exposed to the same contaminants, would definitely we both get the condition, or would one of us maybe be more likely than the other?
There would be a genetic susceptibility to the same exposure, which we know from most diseases. And ethnic groups are different also.
Are ethnic groups more affected?
Well, they're different. You can't say, excuse me, you can't say more or less. Okay, yes.
If we have a patient like with IBS or mast cell activation disorder or other inflammatory diseases, are there any markers in the blood if they've had implants or something else that we could look for to suggest that silicone could be a culprit, or to look at that could be a culprit?
Interleukin-1. And we did studies on these breast implants. We found that all of the T cells in women exposed who were symptomatic had T cell reactivity to silica, silicone, and silicate in the test tube. Yes.
So demethylation is bad.
Is bad.
And methylation is good.
Correct.
Now, why don't you methylate them, everybody? There are things called methylating agents. They were herbicide, pesticide, very out of fashion now. Like dimethyl zinc or methyl bromide. They were used to preserve strawberries and vegetables and almonds. They totally out of fashion. Did anybody take the subjects and put them, give them dimethyl zinc?
Don't know. I'd have to look it up. But I agree with you completely. There was a study done by nutritionists at the NIH on methods of altering your methylation. Folic acid, B12, B complex, high B complex can shut off the demethylation and methylate back the cell that is abnormal. The first time I came across this was a colleague of mine was treating homocystinuria, which is a disease of children who get mental deficiency and complete memory loss. You give them folic acid, the memory comes back.
I'm going to comment on two interesting findings on this. One, that when you talked about methylation and demethylation, a light bulb just went on in my brain. And it turns out that they are studies treating ALS with methylcobalamin,
yes,
a methylated form of cobalamin.
As an antidote, and I have a patient who was exposed to propionitrile, which is another brain toxin. We put them on methylcobalamin.
And that brings to a subject very close to a lot of people with EDS, the methyl tetrahydrofolate reductase, that people with that mutation, especially C677, they have, of course, higher level of methionine, of homocysteine.
Yes.
And people that are treated with methotrexate have higher level of homocysteine. So although I never thought that people treated with methotrexate might get a higher incidence of strokes than other people. I don't know if that's literature in the sense.
And I can't tell you, but I'm aware of what you're saying, and I agree with you. It has to be looked at.
It turns out that the studies on this are in Europe in the 70s, 80s. If the studies from Holland or Norway say that about 10-15% of their population have the mutation, 40% of Italians have it. So methotrexate becomes more toxic in Italy than in Norway. It's like once you have the mutation, kind of you have a bit of methotrexate effect already, because methotrexate now inhibits dimethylfolate and the other one the tetrahydrofolate. So it's kind of, we are already a bit methotrexate exposed, yeah. So just probably we don't need 7.5 milligrams then, we need 5, you know, if we are Italian. So interesting stuff.
Very good.
There is very commonly in Ehlers-Danlos syndrome, there's a B12 deficiency and also MTHFR, you know, alleles occur in seems like 30 or 40% of patients. And I think they also have ferritin deficiencies, and that these seem to be linked. But in light of what he was just saying about the MTHFR and what you were saying about B12, does that increase the proclivity to the methylation response?
I think it methylates more in the presence of B12 folic acid. And the other interesting thing is homocysteine in the is highly inflammatory for coronary artery disease and what have you. And I have treated many of the homocysteine high people with folic acid and B12, and they all normalize. It takes about 3 months to respond.
Can you repeat the beginning of what you just said when you answered Dr. Henderson?
Homocysteine is an amino acid that's prevalent in many patients who get coronary artery disease and stroke. And high homocysteine is bad for your arteries. But we treated them with folic acid, B12, and B complex, and they normalized their homocysteine over a period of 3 months or so.
Did you retest after that?
Yes. Well, we were afraid to take them off because they just...
Exactly, that's one question. Should we keep them for the rest of your life?
Probably.
I also give folic acid to MTHFR patients. But I don't know, should I give it forever? Should I stop?
It's inexpensive and it's a small pill.
And I give 1 milligram, which is a higher dose than in multivitamin, which is 0.2. That's not enough.
I agree.
Thank you very much, Professor. Dorothy, any announcements?
The next meeting is going to be on July 22nd.
July 22nd will be the next meeting. And we may have a speaker on PANDAS. And that's not definite yet. PANDAS is the pediatric autoimmune neuropsychiatric disease associated with streptococcal infections that you were talking about. Anyway, thank you very much for your attention tonight. And Dr. Decker, as you could make it. All right, I know.